Mesothelioma is a malignant cancer disease of the mesothelium, a protective layer of tissue that covers many of the body's organs, such as the heart, the lungs, and the abdominal organs. Mesothelioma is a rare disease being found new each year in about 4,000 patient cases. Mesothelioma is recognized as being caused by exposure to asbestos particles. There are three types of mesothelioma: pleural mesothelioma, which is the most common, peritoneal mesothelioma, the second most common, and pericardial mesothelioma, the rarest of the three. Peritoneal mesothelioma is a cancer that makes up 10 to 20% of the patient cases, and it affects the lining of the abdomen. It is caused by the ingestion of asbestos. Pericardial mesothelioma is the rarest form of mesothelioma, but is frequently found in conjunction with pleural mesothelioma. The pericardium covers the heart and acts as a protective barrier for the heart. Only 150 cases have ever been reported, and people aged 40 to 70 are most likely to have pericardial mesothelioma. Surgical removal of the pericardium is a current treatment, as it lessens constrictions on the heart. Pleural mesothelioma, being the most common, makes up 75% of all mesothelioma cases. It is a tumor that affects the mesothelium covering that protects the lungs. Even though it is the most common case of mesothelioma, it is still rare and is often misdiagnosed with several lung diseases such as lung cancer and viral pneumonia. Mesothelioma and its symptoms often do not reveal themselves until 40 years after exposure to asbestos. If you think you or individuals you know may have mesothelioma, please call 1-800-909-6376 if you or someone you know is interested in our clinical trials. For more information about the symptoms of all three types of mesothelioma, or for specific answers to your particular situation, please call the toll-free number to the Mesothelioma Research Foundation of America. 1-800-909-MESO. That's 1-800-909-6376. Or visit our central website at www.mesorfa.org. Feel free to ask about our clinical trials led by Dr. Prakash Gill.
What is mesothelioma? We've all seen the low-budget commercials in the middle of the night. Malignant mesothelioma is actually an aggressive cancer, with symptoms and warning signs similar to lung and gastrointestinal cancers. The disease originates within the lining of the lungs, heart, and abdomen. The only known cause of mesothelioma is exposure to asbestos. Due to relatively common symptoms, misdiagnosis happens frequently with this disease, so visiting an experienced thoracic oncologist is key to early detection. Treatment methods include chemotherapy and surgical removal of the disease, though prognosis is generally poor at diagnosis. But as awareness of this disease builds, so does hope for all mesothelioma patients. The Mesothelioma Cancer Alliance stands with you in the fight against mesothelioma. Refuse defeat.
And this will be shown by Dr. David Waller. He's a well-known European thoracic surgeon at Glenfield Hospital in Leicester in the UK. And the title of his presentation is that increased investment in thoracic surgical expertise increased the UK lung cancer resection rate.
Paul, thanks very much. So my name's David Waller. I'm a consultant thoracic surgeon, a pure thoracic surgeon. I work in the Glenfield Hospital in Leicester in the United Kingdom. I'd like to summarise the results of a presentation just made by my senior registrar Kelvin Lau at the presidential session. I want to describe to you the effects we found of investing in thoracic surgery on lung cancer resection rates. The background is that in the UK, lung cancer has been undertreated. There is evidence that in comparison to other Western and developed countries, our treatment rates and survival for lung cancer fall way below the accepted standards. This has been focused on by the British media, and hopefully some changes have been made as a result. Within our country of around 60 million people, there is a wide variation in the access to lung cancer surgery. As you can see from this map, there are areas of the country which have a 6-fold greater resection rate. Just to put that into perspective, if you are an elderly patient with lung cancer in Cornwall, you are 6 times less likely to get lung cancer surgery than if you live in Leicester. And clearly this is of major concern both to the patients but also to the politicians. As you can see here, this again has attracted the attention of the British media in the past. This graph shows the resection rate adjusted for various confounding factors such as sex and age. This is a real difference. The background to this is the standard UK lung cancer pathway. Because of our state healthcare system, virtually all cases of lung cancer are referred in from primary care to a specialist lung cancer service. They are initially screened by a chest physician and then discussed at a multidisciplinary team, which will include a chest physician, an oncologist, and hopefully in most cases a surgeon. But this is the first point where the surgeon is involved in the lung cancer pathway. And unfortunately, it is the case in the United Kingdom that not all cases of lung cancer are discussed in the presence of a surgeon at the MDT. The decision is made by the MDT then to refer the case on to the surgeon. And as I'll show you, in the United Kingdom, if you have lung cancer, you may or may not see a surgeon who has a specialist interest in that disease. One of the benefits of this, one of the aspects of this presentation has shown the benefit of the National Lung Cancer Audit, which is a way of recording all the data pertaining to lung cancer patients within our state healthcare system. And our presentation is based on the analysis of its results. Within our national healthcare system, I'm focusing now on England. There are 33 cancer networks comprising 174 hospital trusts. 18% of these trusts have thoracic surgical centres. But in 58% of these trusts, there are less than 2 pure thoracic surgeons. In 2008, which is the last analysed lung cancer audit, over 15,000 confirmed cases of lung cancer were in the United Kingdom, and 14% underwent resection. Data from the Centre for Workforce Intelligence, current data in England, shows this distribution. Less than half of the surgeons operating on lung cancer are pure thoracic surgeons. There are 63 surgeons whose practice combines both cardiac surgery and lung surgery. And there are 114 surgeons whose surgery comprises entirely heart surgery. Our analysis in this presentation related the data from the National Lung Cancer Audit to manpower data obtained from that last source. And these are the main findings. Lung cancer resection rates are higher in centres who treat more cases. Lung cancer resection rates are higher in patients who are first seen in one of the specialist centres, the base centres where there is thoracic surgery, rather than in the referring centres. Importantly, lung cancer resection rates are higher in centres where there are 2 or more specialist thoracic surgeons as opposed to cardiothoracic surgeons. And, reflecting the lung cancer pathway, lung cancer resection rates are higher, significantly higher, when surgeons attend preoperative MDTs. And we found that after the analysis of the 2008 data, there were appointments in 5 of those 31 units of new specialist thoracic surgeons. When we reanalysed the changes in resection rates, surprise, surprise, the increase in resection rate was greatest in those units who had employed new specialist thoracic surgeons. What does this analysis mean? If we look at the implications for the lung cancer surgery workforce, and we take the network that had the best resection rate in that data, they had 3 pure thoracic surgeons who saw 450 new cases of lung cancer per year in their MDTs. And each surgeon attended, on average, 1.5 MDTs a week. So, if we use that as the gold standard, and we apply that across England, for 15,700 cases, we would need 107 thoracic surgeons. And if we looked at the MDT attendance, if we kept the same number of MDTs, we would need 113 surgeons. Now, looking back to that workforce data, if we assume that 63 of those mixed practice surgeons devoted half of their time to lung cancer surgery, which we're not sure that's true, we have a current total of 89 whole-time equivalents. So you can see we are understaffed in terms of specialist thoracic surgical expertise. So the bottom line, if we want to maximise lung cancer resection rates, England needs to recruit 25 to 30 new pure thoracic surgeons. And there are several ways we could do that. We could increase the number of surgeons in training who currently train in both cardiac and thoracic, and increase the number who are specially trained in thoracic surgery and particular lung cancer surgery. Perhaps we could persuade the surgeons who currently have a mixed practice to decide if they want to specialise in either cardiac or thoracic surgery. Failing that, if our authorities don't realise the importance and don't change the training structure, or our hospitals don't realise the importance of our surgeons specialising, we could import new thoracic surgeons from within the EU. But that, of course, would not be particularly acceptable to many of the population or medical specialities. We hear a lot about the developments in new drugs and technology, but I will put it to you that these have borderline effects on the overall survivorship in lung cancer. There is unpublished data as yet to be released that shows that increasing the resection rate has a major impact on the population survival from lung cancer. And there is data to suggest that if everyone, or all the centres, move to the higher resection rate, they could increase survival in lung cancer in England by 12%, which could approximate to over 5,000 extra survivors from lung cancer over a 3-year period. So surgery is still important, vitally important, in the treatment of lung cancer, and the message is specialist lung cancer surgery is even more important. Thank you.
Thank you, Dr. Waller. I think the message was very clear, and the future for thoracic surgery seems bright in the UK. Any questions or comments?
Yeah, Stephen Pinn, Doctors.net UK. The recommendations that you've outlined are very laudable, but given the financial constraints facing the National Health Service in the UK, are they